Our next presenter is Dr. Hua from the USC Roski Eye Institute. Something seems different.
Hello, good afternoon, or good morning, everyone. My name is Hong-Ween Hua. I am a second-year resident at the USC Roski Eye Institute, and I'd love to present you this fascinating case in which something seems a little different, and I have no financial disclosures. So we start today with a 51-year-old gentleman that was recently diagnosed with acute promyelocytic leukemia who complained of sudden blurry vision. Of note on review of systems, they were positive for fever, tachycardia, odynophagia, productive cough with wheezing, as well as marked peripheral edema in his extremities, negative for headache, nausea, vomiting, dysaceusis, meningismus, or skin changes. His past medical history is, as I mentioned before, recently diagnosed APML. He had a prior orthopedic surgery. And his medications, he was recently started on chemotherapy 2 weeks prior to presentation, all transretinoic acid, as well as arsenic trioxide and idarubicin. And he was on vancomycin for neutropenic fever at the time. Social history, otherwise only remarkable for remote history of smoking. He makes tamales for a living, and there's no history of radiation exposure. These are his ocular vitals. He is count fingers in both eyes. There was no RAPD, normal intraocular pressure. He had a little bit of decreased brightness sense in the right eye. His red DSAT was normal. His color plates were down 1 out of 8 due to his visual acuity, and his extraocular movements were full. On slit lamp examination, it was rather unremarkable with no signs of inflammation. And these are his fundus photos 4 days after presentation. He does have bilateral choroidal effusions with white-centered intraretinal hemorrhages. You can note here that there's also these interesting yellow intraretinal lesions as well. And he does have subretinal fluid posteriorly in both eyes. And here's a better view with the Optis fundus photo of the choroidal effusion, in which we can appreciate the ora serrata from the choroidal effusion. And this is the fluorescein angiogram of the right eye demonstrating blocking from the intraretinal hemorrhages. There is peripheral leakage with elevation of the retina, as well as subretinal fluid present as well. And we can appreciate more exaggerated peripheral leakage with elevated retina in the fellow eye. This is the OCT of his macula of both eyes. There is subretinal fluid in both eyes, as well as intraretinal fluid with septae and corrugations of the inner retina.
So what was his white blood cell count?
Great timing. He was pancytopenic.
Okay.
With otherwise unremarkable infectious workup. So I'd like to invite the panel to comment at this time on the differential for bilateral choroidal effusions with subretinal fluid.
So in this type of situation, you're thinking of, first of all, leukemic infiltration, producing those retinal hemorrhages, and you also can get serous detachments from choroidal infiltration. And then infectious causes on top of that, you have to rule out. It also sounds like he we had pedal edema. Was he all swollen?
Yes, he was very swollen.
Yeah, so that could possibly be related. Maybe he has congestive heart failure and backup of fluid into the eye causing the choroidal effusion.
Sandy, you have a comment before you catch your plane? I'll excuse you.
No, I think the hemorrhages, the choroidal detachments, it looks like a leukemic, and it needs to be evaluated for an infectious disease on top of that.
Basil?
I would agree.
All right, keep going.
So I'd just like to review briefly the differential for bilateral serous choroidal effusions. Of course, we have neoplastic, which is at the top of our differential, inflammatory, medication-induced. He had extensive infectious workup as well. He did not have any vascular risk factors, did not have prior surgery, and we did not think it is idiopathic in this case. And so these were at the top of our differential. He had other we would say that inflammatory causes were our diagnoses of exclusion. And so with the diffuse white-centered hemorrhages, we had to think of lymphoproliferative as an etiology, this gentleman's leukemia, and review his medication. So at this time, I'd like to present to you three other cases in which this medication, all transretinoic acid, causes a well-known complication called differentiation syndrome. In this case, there's a 39-year-old gentleman with EPL started on this medication, Atra. He developed systemic manifestations including fever, hypoxemia, had fluid retention, and suffered from refractory differentiation syndrome, and had bilateral subretinal fluid, not quite as impressive as our case, and without choroidal effusions, and also has these interesting kind of yellow spotted stippled macular lesions. Similar case here in a 35-year-old woman that had APL as well, that was started on Atra therapy, had subretinal fluid in both eyes, as well as this hyperautofluorescent modeling posteriorly. This patient also, interestingly, also had bilateral angle closure as well. And this is a third case in which, same case, patient with APL started on Atra, had systemic manifestations including headache, nausea, fever, hemodynamic instability, had decreased vision, and subretinal fluid in both eyes, which had self-resolved. And so what exactly is differentiation syndrome? It occurs in the setting of acute promyelocytic leukemia. It consists of 10% of patients who get an acute myeloid leukemia. And interestingly, it is the first malignant disease to have a highly curable disease with targeted therapy. And it has a chromosomal translocation of 15 and 17. And the mainstay induction therapy for this disease is all transretinoic acid and arsenic trioxide, which induce terminal differentiation of these malignant blast progenitors. And it's a very common complication, occurs in 1 out of 4 patients receiving this chemotherapy. And it's also important to recognize because it is life-threatening. It can be potentially life-threatening. And so the hypothesis is that it induces this release of cytokines, causing a capillary leak syndrome from the differentiating myeloid cells. Typically, systemically manifests with unexplained fever, respiratory distress, marked peripheral edema with pulmonary infiltrates, and you can also appreciate radiographic lung opacities. And I highlighted in red the systemic manifestations that our patient had. So what did we do? I called the hematology oncology team. I said, maybe this is from his leukemia, but also since you, the primary team, were concerned for differentiation syndrome, and we found case reports which also demonstrated this subretinal fluid, we said that, okay, this may be differentiation syndrome manifesting in the retina and the choroid. And so he was started on IV dexamethasone. 2 hours later, at 2 in the morning, his chemotherapy was held. And so he presented count fingers and then markedly improved just in 4 days, was 20/70, 20/50. And then 8 months later, he now pinholes to 20/20. And so this is his imaging 6 weeks later. He has a resolution of the choroidal effusions. Interestingly, kind of similar, has these yellow hypopigmented modeling areas posteriorly with resolving white-centered intraretinal hemorrhages. And his OCT is now flat with still some patchy loss of the ellipsoid zone. So just to summarize, bilateral serous retinal detachments has been reported in 3 other cases, but this is the first case of bilateral choroidal effusions with subretinal fluid as a result of the differentiation syndrome manifesting in the eyes. And it's a life-threatening complication, so important for us to contribute to this diagnosis, and it can manifest systemically with fever, hemodynamic instability, peripheral edema, pleural pericardial effusions. And patients with ophthalmic and systemic signs of differentiation syndrome should be promptly treated. These are my references, and I'd like to thank Dr. Mushfeghi and Dr. Reyes for their assistance in our patients' care.
Any comments from our experts?
So we also had some leukemic retinopathy there also, and the leukemia was getting better at the same time as the patient was getting better, so that might have played a role also.
Is there anything about the timing that the audience should know about when people usually get this? I don't know if I missed that during
Yes, it typically happens 1 to 3 weeks after starting therapy of the all transretinoic acid.
And I would like to point out how helpful case reports can be.
Mm-hmm, absolutely.
It would be nice if we had our editor on the board now.
He saw it and noticed that one of the cases was published in his journal.
Yes,
so.
exactly.
Okay, thank you very much.